بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is a new series of diagnostic radiology presented in English according to the requests from many of my colleagues all over the world that they would like to hear this series in pure English, not mixed with Arabic as I used to do. And I will start this new series, which will be referred to by the letters DRE, meaning Diagnostic Radiology in English. And this series will start by imaging of the brain or the neuroimaging. And in this series, we may have about 10 lectures, starting by the anatomy, then the cerebrovascular stroke, imaging of the brain tumors, imaging of intracranial cysts, intracranial calcification, intracranial vascular malformations, diagnostic imaging of intracranial infection, and the intraventricular and the posterior fossa neoplasms. First, we'll start by the anatomy, and as you all know that in order to have a CT or an MRI of the brain, the patient may have some preparation, and this preparation is only the patient is instructed to fast for about 4 to 6 hours. 4 if he is a child, 6 if he is an adult. And this fasting is because of one of two things: either we intend to inject the contrast material, or the patient may have some sort of anesthesia. And actually, the brain examinations now performed by CT scan are usually done first before injecting contrast material. Then the examination is checked on the machine by one of the staff. Then he decides whether the patient is in need for contrast injection or not. And then we usually need to inject contrast material whenever we are suspecting intracranial infection or neoplasms. And we do not usually need the help of contrast media if the patient, if the examination is normal, or there is some atrophic changes, or there is some hemorrhage or infarction. Then we'll expose all these facts along with going through this course in full details. Then in order to have the CT scan of the brain, we put the patient on the machine and we have the scanogram. And this scanogram is performed in the lateral view in order to localize the area to be scanned from the base of the skull and ending by the skull vertex. And we usually align the baseline to the orbitomeatal line, which is the radiographic baseline of the skull. And if we adjusted this line to the orbitomeatal line, we'll see the anatomy I will explain in a minute. But if the angle is not that performed, some of the anatomic details will not appear, as I will explain now. Then in order to have sections in the brain, for adults we proceed every 10 millimeter slice intervals, and 7 millimeter for children, and we may have 5 millimeter scans in cases of infants. Then after finishing the exam we may have the series as you are looking at, starting from the base of the skull, proceeding upward until you reach the top of the skull. Then in order to examine the skull or the brain by MRI, we usually have a sagittal localizer and started the examination from the skull base, the region of the foramen magnum. There is no angle here, and we proceed upward until we reach the vertex of the skull. And in this case, we usually have the slice thickness of 5 millimeter, and we may leave or may not leave an interslice gap of 1 or 2 millimeters. Then starting by the region of the foramen magnum, proceeding upward, and in this case, there should be some sections in the brain whenever you are cutting through the cerebellum, and then part of the occipital lobe will be behind the cerebellum, as you can see in this axial image. And this is the cerebellum, and look carefully posteriorly and you see the cortical sulci of the occipital lobes. This is not the case for the brain scans because we have an angle, and this angle usually do not allow cutting the cerebellum and the occipital lobe in the same plane. Then the usual MRI protocol of the brain should include an axial T1, axial T2, and axial flare, which is the fluid attenuation. This flare belongs to the T2, except that the CSF is black. Then you see the sagittal T1 weighted image, and here are the 4 pulse sequences used for examination of the brain by MRI. Then in the early days of MRI, we used to have a pulse sequence which is known as the proton density image, and this pulse sequence has been totally replaced by the flare image. And in order to know the value of the flare images, and this is an example of a T2 axial section of the brain where a lesion is seen adjacent to the frontal horn of the right lateral ventricle. And this lesion, because of its water content, will appear black in the T1 similar to the ventricle, and bright in the T2 similar to the ventricle as well. But look in the flare image, and the lesion will appear bright because this is a T2 image, where the CSF will appear black because this is a fluid attenuation image. And in another example, you see a patient with 2 infarctions in the brainstem. And these infarctions, one is relatively recent and one is old. Both infarctions will appear somewhat black in the T1 weighted image and somewhat bright in the T2 weighted image, but the flare will differentiate between the old infarction and the recent one. The recent one will appear bright, similar to the T2 weighted image, while the old one will appear black, similar to the CSF, because it is a chronic infarction. Then in order to identify the anatomy of the brain, we should have some of the anatomic landmarks. We'll start by what's known the infratentorial anatomy, which is the anatomy of the posterior fossa. And the anatomy of the posterior fossa, the anatomic landmark here is the 4th ventricle. Then if you look to this sagittal MR T1 weighted image, and you see this is the 4th ventricle, then anterior to the 4th ventricle you will identify the brainstem, and posterior to the 4th ventricle you will see the cerebellum. Then look carefully at the 4th ventricle. The 4th ventricle is large in the middle, and it becomes smaller while going down and also smaller while going up. Then if you cut the 4th ventricle when it is large, then the largest part of the brainstem will be anterior to the 4th ventricle, and this is the bones. Then here's the 4th ventricle, and the 4th ventricle now is large. Then this is the largest part of the brainstem, which is the bones. Then knowing that this is the bones, and this is the cerebellar hemisphere on the left side, and this is the right cerebellar hemisphere, and in the midline you have part of the cerebellum which is known as the cerebellar vermis. Then anterior to the 4th ventricle you see the bones. Anterior to the bones you see this famous artery which is known as the basilar artery, and the basilar artery lies in a very important cistern which is known as the prepontine cistern or the retrocellular cistern. This is the dorsum celli. Then the prepontine cistern will have an extension on the left side and an extension on the right side, and these are known as the cerebellopontine angle cisterns or the ambient cisterns. Then putting your finger on the 4th ventricle, then you know that this is the bones, and this is the basilar artery, this is the prepontine cistern, this is the ambient cistern, and this is the left cerebellum, and this is the right cerebellum, and this is the cerebellar vermis. And posterior to the cerebellar vermis, you'll see the cisterna magna, and the cisterna magna, one of the largest basal cisterns. Then the junction between the cerebellum and the brainstem here in the case of the bones, and this is known as the cerebellopontine junction. And you know that the three parts of the brainstem, the medulla oblongata, the bones, and the midbrain are connected to the cerebellum through the cerebellar peduncles. And the cerebellar peduncles are the inferior one, the middle, and the superior. The middle cerebellar peduncle is the largest of them, and this is the site of the middle cerebellar peduncle, which joins the bones to the cerebellum. We have one on the left and one on the right. Then by MRI T1 and T2 weighted image, you should see the same anatomy. This is the fourth ventricle, this is the bones, this is the cerebellopontine junction or the middle cerebellar peduncle, this is the left cerebellar hemisphere, this is the cerebellar vermis, and this is the right cerebellar hemisphere. Also, you can identify the cisterna magna posterior to the cerebellar hemisphere. And in this MRI, you may be able to identify this line, and this line is one of the more important cranial nerves, which is the trigeminal nerve. And the trigeminal nerve comes out from the bones, and it goes into the cerebellopontine angle cistern, and then through the skull base foramina in order to reach its ganglion in the paracellular area, as we will discuss later on. Then the basilar artery will appear in MRI images in MR as a black dot in both T1 and T2 weighted image because of the well-known signal void phenomena, as I hope you all know. Then look at the anatomic details I have written here. This is the fourth ventricle, and this is the bones, and this is the basilar artery, and this is the prepontine cistern, and this is the cerebellopontine angle cistern. And on MRI, especially in the T1 weighted image, you can identify the trigeminal nerve, and usually you cannot see in the CT images. Then if you go below the level of the fourth ventricle, when it is large, then the fourth ventricle will become smaller and smaller. Whenever the fourth ventricle is smaller inferiorly, then the part of the brainstem anterior to the fourth ventricle now is the medulla oblongata. And here you can see the medulla oblongata. This is the left cerebellar hemisphere and the right cerebellar hemisphere. The cerebellar vermis is not here, it is above. This is the cerebellar vermis, and this is the cerebellar vermis. But what you are seeing now is a CSF space running inferior to the cerebellar vermis, which is known as the vallicula. And this is the vallicula, and here you can see the cisterna magna, which is posterior to the cerebellum, and the cerebellar vermis is seen above, relatively above the vallicula itself. Then you can see this CSF space surrounding the medulla oblongata, and if there is a defect in the CSF space surrounding the medulla oblongata, then you will see the inferior cerebellar peduncle joining the medulla oblongata to the cerebellar hemisphere. And you may be able to see it or may not, because it's very small. Also, the superior one is also small. Then look at these MRI images. This is T1, and you can see the medulla oblongata, and this is the fourth ventricle, which is a small cerebellar hemisphere on the left and on the right. And this axial T1 weighted image, you can see the fourth ventricle, and this is the trigeminal nerve, is clearly identified here. This is the region of the basilar artery in the T1 and in the T2 weighted images. Then whenever the fourth ventricle is small from the inferior sections, then you are in front of the fourth ventricle, you will see the medulla oblongata. If the fourth ventricle is large, then you see the largest part of the brainstem, which is the bones. Then above this level, the fourth ventricle will become also smaller. Then you will start to see the midbrain. And here you can see this is the classic configuration of the midbrain, and the midbrain is surrounded from its posterior aspect by a very important cistern, which is known as the quadrigeminal cistern. And this dot represents the end of the fourth ventricle and the start of the aqueduct of Sylvius. And the aqueduct, as you all know, joins the fourth ventricle to the third one. Then here, this is the midbrain with the classic configuration, bordered posteriorly by the quadrigeminal cistern. And then you know that this is known as the cerebral peduncle, and we have only one cerebral peduncle, and this is the cerebral peduncle on the left, and this is the cerebral peduncle on the right. And this CSF space is known as the interpeduncular cistern. And in this interpeduncular cistern, important structures will be mentioned immediately now. Then look at the CT image and you can identify the quadrigeminal cistern with the terminal part of the fourth ventricle and the start of the aqueduct of Sylvius, and you can identify the brain, the midbrain. Here also, this is the superior part of the cerebellum, and this is the terminal part of the fourth ventricle passing towards the aqueduct of Sylvius, and this is the start of the midbrain. Then, in this image, you will see this horn, which is the temporal horn of the lateral ventricle. You know that the lateral ventricle has three horns: the frontal horn, the occipital horn, and the temporal horn. Then the first horn you will see while you are coming from inferiorly, then this is the temporal horn, and the structure between the temporal horn of the lateral ventricle and the midbrain, this area I mean, is known as the hippocampal formation. And this hippocampal formation contains two important structures, which are the amygdala or the amygdaloid nucleus and the hippocampus itself. This area is very important in patients with temporal lobe epilepsy because the lesions usually are seen in this particular area. Then the most famous lesion affects this area is known as mesial temporal sclerosis. And mesial means medial, temporal means temporal, sclerosis means gliosis. And this is the classic appearance of the hippocampus in the coronal images. And you can see its intimate relation to the temporal horn of the ventricle. And this is on this side, this is the normal size of the hippocampus, and here this is an atrophic hippocampus with abnormal texture. This is enough for the diagnosis of mesial temporal sclerosis, a good reason for temporal lobe epilepsy. And this patient had abnormal signal along the whole parts of the hippocampus. And you know the hippocampus has a body, a head, body, and the tail. And look at the right side, and these are the flare images where the lesions are bright and the CSF is black. And this is the region of the hippocampus, which looks somewhat bright, the head of the hippocampus, and you are passing to the body of the hippocampus in this area, and finally you came to the region of the tail of the hippocampus, and we'll explain this also in a moment now. Then look at the coronal image, and this is the region of the hippocampus on the right side, and this is the region of the hippocampus on the left side. The diagnosis of mesial temporal sclerosis is based on a change in the signal of the hippocampus or a change in the volume of the hippocampus, or both, a change in the signal and a change in the volume. And this is an example of a patient with temporal lobe epilepsy, where you can see the temporal horn of the right lateral ventricle is dilated. And if you look carefully here, and you can see that the region of the hippocampus shows somewhat abnormal signal. But come to the coronal image and compare the normal hippocampi with this hippocampus, which is abnormal. Look at here, there is an evident increase in the signal of the hippocampus compared to the normal one on the left side, and this is diagnostic of hippocampal or mesial temporal sclerosis. Then at the level of the tentorial hiatus, you will see the quadrigeminal cistern. And in the middle part of the quadrigeminal cistern, you will see the terminal part of the fourth ventricle and the start of the aqueduct of Sylvius. Then you can see the midbrain, and you can see the peduncle, the cerebral peduncle, and you see the interpeduncular cistern. And in this interpeduncular cistern, you will see two very small rounded structures, and these are the mammillary bodies. And if you look here in the T2 weighted image, you can also identify the mammillary bodies. If you go slightly anterior, and you will see two lines like this, and these are the optic tracts after coming from the decussation of the chiasm above the cella. Then this is the optic tract on the left, and this is the optic tract on the right side. This is the aqueduct of Sylvius, and here is the cerebellar folia identifying the superior part of the cerebellum. Then we came to the level above the tentorium, which is known as the basal ganglia level. In this basal ganglia level, we identify the frontal horn of the lateral ventricle and the occipital horn of the lateral ventricle, and also you can see the third ventricle in the midline. In this section, you can identify most of the basal ganglia, which are the caudate nucleus here, the lentiform nucleus here, and the thalamus. The caudate nucleus, the head, particularly the head of the caudate nucleus, lies in the concavity of the frontal horn of the lateral ventricle, and this is its site by CT and clearly identified by MRI T1 and the T2 weighted image. This is what we call the head of the caudate nucleus. Then lateral to it, you'll see this triangular configuration, which is the lentiform nucleus, and this is the lentiform nucleus here. Then on either side of the third ventricle, you will see the thalamus. This is the left thalamus, and this is the right thalamus. Here, this is the lentiform nucleus, and this is the thalamus, the lentiform nucleus, and the thalamus. This is the third ventricle, occipital horn, and the frontal horn. Then between the caudate, lentiform, and the thalamus, a very important structure which is known as the internal capsule. And this internal capsule can be easily identified by MRI T1 and T2 weighted image running between the head of the caudate nucleus, the lentiform nucleus, and the thalamus. It has an anterior limb, a genu, and the posterior limb. Then in this section, you remember, you have the tail of the hippocampus at this area, and we'll explain this also in another image. Look at this image, and you can see the frontal horn, and this is the third ventricle, and this is the occipital horn on both sides. Then this area belongs to the head of the caudate nucleus, and this area belongs to the lentiform nucleus, and this area belongs to the left thalamus. Then if you look carefully here, and you can identify the internal capsule. Then look at the anatomic details here. Can you see the head of the caudate nucleus? Yes, and this is the lentiform nucleus, and here is the site of the thalamus, and you can identify the region of the internal capsule. Then you remember the quadrigeminal cistern, which was bordering the posterior part of the posterior aspect of the midbrain. In the higher section, you will see the quadrigeminal cistern as rhomboid in shape, or it has some sort of a quadriangular structure like this one. This structure has four recesses, an anterior one, posterior one, and two lateral recesses, as you can see here. This is the quadrigeminal cistern, which is rhomboid in shape, and it has an anterior recess, posterior recess, two lateral recesses. Inside the quadrigeminal cistern, there are four structures: the pineal body, which usually calcifies in adults, and the two internal cerebral veins, as well as the vein of Galen. Then the lateral recess of the quadrigeminal cistern, which is this one, is known as the retrothalamic cistern. This part is behind the thalamus, so it is known as the retrothalamic cistern, and also that on the right side. Then the posterior recess lies above the cerebellum, so its name is the superior cerebellar cistern. Then the anterior recess runs above the third ventricle, and it is known as velum interpositum, and frequently this velum interpositum may dilate and contain CSF, and is known as cavum velum interpositum. Then look at the anatomy, the anatomic details. Can you see the caudate nucleus? This is the head of the caudate nucleus, the lentiform nucleus, the thalamus, the internal capsule, the quadrigeminal cistern, rhomboid in shape. Then what is the choroid fissure? And some of the anatomic books say that this recess, which is known as the retrothalamic cistern, can be also referred to as the choroidal fissure. Posterior to the choroidal fissure is the hippocampal tail. Here, this is the region for the tail of the hippocampus. Then the pineal body, which is calcified in the middle part of the choroid plexus, and you can see calcification in the occipital horns of the lateral ventricles belonging to calcification in the choroid plexus. Then if you go up, then you will cut in the body of the lateral ventricle. And the bodies of the lateral ventricles are standing in the midline, separated by the cavum by the septum pellucidum. And if you look carefully adjacent to the body of the ventricle, you will see a relatively dense structure which represents the body and the tail of the caudate nucleus. You remember the head of the caudate nucleus lies in the concavity of the frontal horn of the lateral ventricle, and this is the remaining part of the caudate nucleus, which is the body and the tail. Then each cerebral hemisphere is made of the white matter and the gray matter, with well-identified gray-white matter interface. Both hemispheres are separated in the midline by the interhemispheric fissure. Then above the level of the ventricle, you will see only the left cerebral hemisphere, right cerebral hemisphere, the white matter, and the gray matter. And here in the T1 weighted image, the white matter is white, the gray matter is gray. But in the T2 weighted image and in the CT, the white matter is dark and the gray matter is relatively bright. Then, in order to know the anatomic localization of the lesions or structures seen in both CT or MRI, then if you look to the section like this, and then you can identify a lesion here, and you will say this is the left cerebellar pathology. Here, this is the pontine lesion. And in this area, which belongs to the inferior part of the temporal lobe, and this area belongs to the inferior part of the frontal lobe. Then if you came to the level of the ventricles and the CT images, you may draw two lines like this, one in front of the ventricles and one behind. And you know that the tissue anterior to the first line will represent the frontal lobe. The tissue posterior to the second line will represent the occipital lobe. Then in the higher section, you should identify this area in the middle part of the brain between the two lines. If you are cutting inferiorly, you will see the temporal lobe. If you are cutting superiorly, then you will see the parietal lobe. How can you know that you are cutting inferior or superior? Then look at the third ventricle. If you see the third ventricle, then the section is inferior, and this is the temporal lobe. If you see the body of the ventricle, then the section is superior, then you see the parietal lobe. But what happens if there are no ventricles? You draw three lines dividing the section into four equal parts. And the anterior part belongs to the frontal lobe, while the rest of the 3/4 belong to the parietal lobe. There is no temporal and no occipital. The occipital lobe is very small and it does not reach this high level. Then if you came higher up in the section, you are only left with the parietal lobe. No more frontal lobe and no more occipital or temporal lobes. Then you know that the fibers come through the spinal cord and pass through the internal capsule and come out in the form of radiating fibers, what is known as the coronal radiata, reaching the terminal parts in the subcortical area, which is known as the centrum semioval. Then if you look to this coronal image, and you can identify this is the site of the internal capsule, and this Part of the white matter represents the area of the corona radiata, which is near to the ventricle, the white matter which is near to the ventricle. And you can see these are the fibers coming through the spinal cord, passing through the internal capsule, coming as the corona radiata, then ending into the subcortical area as a centrum semioval. Then we came to the vascular anatomy of the brain as seen by CT and by MRI. And you know, in the axial sections, you cut the internal carotid artery as a circle. This is the site of the internal carotid artery in the supracavernous part. Then the internal carotid artery will give a lateral branch, which is the middle cerebral artery, and the medial branch, which is the anterior cerebral artery. The anterior cerebral arteries run parallel in the midline, and they are joined in the suprasellar cistern by the anterior communicating artery. And you see this is the anterior communicating artery. Meanwhile, the basilar artery is coming from the posterior fossa at the tentorial hiatus, and the basilar artery will divide into two posterior cerebral arteries. The posterior communicating artery connects the internal carotid to the posterior communicating artery, and this is known as the circle of Willis. Then if you look at for MRI, better in the coronal images to identify the exact anatomy, and you can see this is the internal carotid artery, and this is the middle cerebral going to the region of the sylvian fissure, and this is the anterior cerebral going to the midline. And what are the values of the sagittal images in MRI? Number one, anatomic localization of the lobes. In this sagittal image, you can easily say this is the frontal lobe, and this is the parietal lobe, and this is the occipital lobe, and this is the cerebellum, this is the medulla, this is the bones, and this is the midbrain. And this anatomic localization can be achieved in a single image. In order to see the temporal lobe, you should go either to the left or to the right, as you all know. Then one of the important values of the sagittal images is the identification of the corpus callosum, and this is the corpus callosum, and you know that it's composed of four parts: the rostrum, the genu, the body, and the splenium. And this is, in my opinion, the only way to assess the corpus callosum accurately is the sagittal images, especially the T1. Then assessment of the craniocervical junction: lesions near or at the foramen magnum, lesions coming from intracranial into the upper part of the cervical canal, or the opposite direction, are easily identified in this sagittal images, like the Chiari malformation, and so we'll discuss this with the lecture of hydrocephalus. Then evaluation of the venous sinuses for venous sinus thrombosis, and this is a good view to see the most important sinuses, especially the superior sagittal sinus, the straight and the transverse sinuses. And one of the important values of the sagittal images is the assessment of the pituitary gland. If you have a sagittal image without intravenous gadolinium injection, you can easily identify the difference between the anterior pituitary and the posterior pituitary. The posterior pituitary contains more triglycerides, more fat, so it appears relatively bright in the T1 weighted image compared to the anterior pituitary. But if you inject contrast media, both lobes will enhance homogeneously, and you cannot identify the posterior from the anterior one. Then these are the sagittal images, and you all know that we start in the sagittal images from left and you proceed to the midline, then we reach the right side of the patient. Then if you are asked about this lobe, this is the left frontal lobe, and this is the left temporal lobe, and this is the left cerebellar hemisphere, and this is the left parietal lobe, and so on. But in the midline image, you should not see any brain tissue. You should see only a CSF, like this sagittal T2 weighted image, and you can see CSF in the midline. This can be seen if you are cutting exactly in the interhemispheric fissure. But this is not the case in every patient, and you may have this midline image containing brain tissue, and you can, by reading the data on the image, know whether this image is relatively to the left or to the right side of the patient. Then the coronal images are not routine in the MRI examination of the brain. But the coronal images are valuable, especially in assessment of the pituitary lesions, as we will discuss in the lecture of the cell. Then the coronal images, are very important in assessment of the hippocampal region to diagnose mesial temporal sclerosis. Also, they are important to identify the vascular anatomy. You can see, especially the T2 weighted images, where you can see the internal carotid artery, the middle cerebral artery, and the anterior cerebral artery. You remember that the trigeminal nerve is seen in the axial images, but if you have a coronal image like this, then you will see the trigeminal nerve on both sides of the brainstem. And this is the cut section of the trigeminal nerve, and you can also evaluate. Sometimes you can evaluate the skull base and the posterior fossa, especially in the coronal images. If there are lesions coming from the nasopharynx, for example, invading the cranium, or lesions from the intracranial space coming outside the skull. Then you remember the anatomy of the hippocampus, and you can see this is the normal signal and the normal volume of the hippocampus on the right side and the hippocampus on the left side. You may have T1 and T2 3D images, especially in cases of epilepsy, where you know that we have an epilepsy protocol, which should include the coronal images in T1 and T2 weighted images, and also the FLAIR images. You remember in the era before MRI, we used to examine the carotid circulation through the selective carotid angiography using the digital subtraction techniques, as you can see. But nowadays we can use the CT angio, we can use the MRI, like this image. You can see this is the internal carotid artery, middle cerebral, anterior cerebral, or you can use the MRA or the MR angiography, whether without injecting contrast media or with injecting contrast media, to obtain these beautiful images for the carotid circulation. And this is an example of MR angiography of the brain presented in the axial plane. And you can see similar to the CT, and this is the site of the internal carotid artery, and this is the middle cerebral artery and its branches in the sylvian fissure. This is the anterior cerebral artery. This is the region of the anterior communicating artery. And here you should see the tip of the basal artery. This is the posterior cerebral on the left and the posterior cerebral on the right. Then we came to the normal venous anatomy. And you know that we have important venous sinuses intracranial, and the most important one is the superior sagittal sinus, and this is the anatomic location and the course of the superior sagittal sinus. The inferior sagittal sinus is similar to the superior one, parallel to it, but is very small compared to the superior sagittal sinus. Then the vein of Galen is seen here, and it joins the inferior sagittal sinus in order to form the straight sinus. And this is the region of the straight sinus. And here, number 14 refers to the confluence of the sinuses, the superior and the straight, as well as the transverse sinus. Then you can see the transverse sinus, number 15, and the sigmoid one, number 16, and number 17 refers to the internal jugular vein. Then this is the superior sagittal sinus, and this is the vein of Galen, and this is the inferior sagittal sinus. This is MR venogram, and here is the straight sinus, and this is the confluence of the sinuses. This is the transverse sinus, and this is the sigmoid sinus, and this is the internal jugular vein. Then look at the axial images. You can see the transverse sinus here, and this is the confluence of the sinuses in the midline, and the transverse sinus leads to the sigmoid sinus, and it will lead to finally to the internal jugular vein. And you remember, this is the jugular fossa in the petrous bone. Then in the axial MR venogram, you will see this is the internal jugular vein in the jugular fossa, and this is the sigmoid sinus, and this is the transverse sinus, and this is the confluence of the sinuses. And this is in a coronal oblique view, where you can see the superior sagittal sinus, and this is the straight sinus, and this is the transverse sinus, and this is the sigmoid sinus, and the internal jugular vein. And by this we can finish the normal anatomy of the brain by CT and by MRI. Also, we presented some knowledge about the venous anatomy and the arterial anatomy, and I thank you very much.